Today we'll start with three small topics. I'm the founder of Aiobio and also a CEO who actively uses this in clinical settings. After today's lecture, our co-founder Professor Baigil Kim and the inventor of QLF technology, Dr. Elbert, will join us for the Q&A session. There are various types of light-induced reactions. Among them, we focus on fluorescence. Unlike other reactions, fluorescence is characterized by emitting light at a different wavelength than the light it absorbs, and our technology leverages this unique property. Our technology originated with a method called QLF. Dr. Elber first presented this technology at the ORCA conference in 1993, and it has since seen significant advancements. In 2004, the first device approved by both the FDA and ADA in the United States was released. As you can see on the monitor, the early devices primarily focused on detecting green fluorescence emitted from natural teeth. When the device was introduced to Korea, I started using it in clinical settings, and over time it evolved into the clinical equipment we have today. As shown in the image on the left, when teeth are exposed to 405 nanometer blue light, they emit a green autofluorescence. This technology utilizes the red fluorescence emitted near 700 nanometers from the biofilm surrounding the teeth. In other words, it enables us to detect abnormalities in the biofilm, which often indicate underlying issues with the tooth. Although natural teeth may appear completely normal to the naked eye, they exhibit green autofluorescence when imaged. We have applied a special filter to convert this green fluorescence into a more natural-looking ivory color. The red areas shown in the image correspond to the biofilm emitting long wavelength fluorescence, as mentioned earlier. Sometimes when the biofilm penetrates the tooth surface itself, those areas also exhibit red fluorescence. On the other hand, very healthy teeth do not show red fluorescence. They maintain their natural green autofluorescence, which appears as ivory through our special filter. As I will explain later, our MCA, multichromatic analysis, shows that all pixel values recognized by AI in these healthy regions fall within the green zone. Because we understand the typical fluorescence profile of healthy teeth, even minor changes, such as those seen in the very early stages of caries, can be detected through subtle shifts in fluorescence. This allows us to identify the disease earlier than with traditional X-rays, which typically detect only progressed caries. Many people have traditionally relied on disclosing solutions. While these solutions do reveal the presence of oral biofilm, they require the application of dye, a major drawback. Do you think patients actually like that? Chances are they don't, and what's worse, it takes extra time to remove the dye afterward. Our technology essentially functions as a digital disclosing solution, requiring no dye and displaying results in real time, just like the image on the right. The image on the left shows the result of using dye. Eliminating this kind of inconvenience is one of our biggest advantages. Biofilms that develop after colonization by bacteria, such as Fusobacterium, known as late colonizers, are characterized by the presence of porphyrins. Due to the chemical structure of porphyrins, when light is applied, they absorb a specific amount of energy, and the excess energy is emitted as long wavelength red fluorescence. This red fluorescence indicates that the biofilm has been present for more than 3 days, corresponding with the emergence of late colonizers. It ultimately signifies that the bacterial environment has shifted from a healthy to a pathogenic state. And the biggest advantage is that we can visually detect truly pathogenic biofilm without the need for dye, unlike benign biofilm that exists in a healthy mouth. If we can visually detect the bacteria responsible for our two main dental diseases, caries and periodontal disease, then we gain a powerful tool for preventing chronic oral diseases, which is precisely where the value of this technology lies. Furthermore, if we combine this with the widely used X-ray technology, we can achieve great synergy. It enables early diagnosis and prevention of both major dental diseases, which is a major clinical benefit. We don't just provide images, we extract both quantitative and qualitative evaluations from them. By combining these evaluations with lifestyle factors, we believe we can effectively predict chronic conditions like caries and periodontitis, and we're actively conducting research in this direction. So, While we're already offering many services, our ultimate goal is to deliver diagnostic results based on fluorescence imaging in dentistry. We aim to share these results with both clinics and patients through a web-based platform called LinkedIn's. This is the foundation of what we pursue with Bliss technology. Next, I'd like to talk about the devices built on this technology and how they are used clinically. We've developed 4 types of hardware tailored to the different clinical stages, and we also have a platform to quantitatively and qualitatively evaluate the resulting imaging data. Let's begin with the imaging devices. We offer extraoral camera type devices that allow full mouth imaging, similar to DSLR or panoramic views. We also provide intraoral cameras, devices designed to be used inside the mouth, similar to those currently used in clinics. These devices are referred to as LinkedIn's QC and QP. The QC model works similarly to DSLR systems commonly used in dental clinics. However, our system captures and provides 2 images simultaneously. First, we focus using a white light image, and at the same time we acquire a corresponding fluorescence image. Just like there's a learning curve for taking X-rays, using our imaging system also requires training. To support this, we provide a web-based training platform called Bliss XP. This platform provides comprehensive training through video lectures and hands-on practice. As shown in the image, there's a clear difference between the image quality produced by a user with 3 years of experience versus one with just 1 month. But I believe this can be fully overcome through proper training, and we've already seen successful cases of this in Korea. Let's take a look at an image captured with this device. This photo was recently taken by a colleague. You can clearly see a significant accumulation of biofilm covering the entire tooth. This case highlights how biofilm can be virtually invisible to the naked eye, yet present in substantial amounts on the tooth surface. Here's another case. The anterior teeth show relatively low amounts of biofilm, but as you move toward the posterior teeth, the amount increases significantly. A notable pattern is that in right-handed patients, the left side is usually brushed more thoroughly at the beginning, while the right side, brushed last, tends to show heavier biofilm accumulation, as seen here. Naturally, you might wonder what happens when surface caries and biofilm coexist. How do we handle that situation? In such cases, we might see biofilm present on the lower arch, but relatively absent on the upper, while still detecting surface caries. This shows the importance of removing surface biofilm before imaging in order to accurately detect fluorescence anomalies originating from the tooth itself. Once the surface biofilm is removed, we can then observe the intrinsic fluorescence abnormalities of the tooth. We would diagnose this as early-stage caries based on fluorescence irregularity. One of the device's most valuable features is its ability to reveal conditions like craze lines and abfractions, things we could previously only assume based on external symptoms. As seen here, craze lines, often invisible to the naked eye, become detectable through fluorescence imaging. And if those craze lines appear red, it suggests not only structural damage, but also bacterial penetration into the tooth. Next, let's look at an image of the occlusal surface. Usually we rely on visual cues such as dark spots on the occlusal surface to explain to the patient why we're recommending an X-ray. However, with Bliss technology, we can immediately obtain red fluorescence signals as visual guidance. Patients show less resistance to imaging because it's non-radiographic, and even those who regularly refuse X-rays can be evaluated using these fluorescence images. This is a mandibular image from the same patient. You can clearly see the red fluorescence within the circled area. So after scaling and removing the surface biofilm, we move on to the next step using the QP intraoral camera. As in the previous case, we first detect abnormalities before scaling, then remove the biofilm and perform a second, more precise QP scan. Previously dark or ambiguous areas in the standard image now reveal red fluorescence from deeper layers. This suggests that the caries may have already progressed into the dentin. Here's an image of the patient's lower left first molar, tooth number 19. While the tooth appears normal to the eye, you can see red fluorescence beneath the resin filling. So, with the patient's consent, we took a bite wing radiograph. The radiograph confirmed proximal caries in the upper premolars and progressed caries in the lower left first molar, tooth number 19. Just like with other equipment, there's also a learning curve for using the QP device. Since it captures both a white light and a fluorescence image at the same time, unlike conventional intraoral cameras, it requires slightly more time and careful positioning in the mouth. Also, to avoid fluorescence interference, the dental overhead light must be turned off during imaging. Experienced users typically need about half the time to capture a proper image compared to beginners. Here's another case. Although nothing unusual is visible to the naked eye, we detected red fluorescence beneath the resin filling, and the X-ray confirmed advanced caries progression. Of course, it would be ideal to take a bite-wing radiograph or X-ray every time, but it's becoming more common to encounter environments where X-rays aren't feasible. In settings like mobile dentistry or teledentistry, where X-rays are restricted to clinical environments, we believe BLIS technology could serve as a viable alternative. Even after removing the caries, it's difficult to confirm with the naked eye whether the removal is truly complete. Often the surface appears clean visually, but residual red fluorescence indicates lingering infected areas. That's why this device is frequently used to support communication with patients, deal with insurance claims, and provide legal documentation if necessary. As periodontal care improves and aging patients retain more of their natural teeth, we're seeing a rising number of cases involving tooth fractures and cracks. When red fluorescence appears along a craze line, it strongly suggests that bacteria have already infiltrated the crack, making it a serious concern. The patient came in complaining of pain in the upper second molar. A visible craze line was present, so we proceeded with endodontic treatment. Even after initiating root canal therapy, we observed the craze line extending down along the enamel wall. This next case involves a more severe condition. The patient had undergone root canal therapy, but during the procedure, we discovered that the craze line extended below the pulp chamber all the way to the root, leading to extraction. Before having these kinds of visual images, it was difficult to obtain patient consent for such invasive procedures. However, with these images, we were able to gain the patient's full understanding and consent, and the case was later published in the Journal of Endodontics in 2021. This demonstrated that BLIS technology can be used to detect craze lines, and based on that, I strongly advocate the following. I question the American Association of Endodontists' long-standing position that the prognosis for craze lines is generally excellent. So I believe that craze lines without red fluorescence can still be considered to have an excellent prognosis, but those showing red fluorescence should be treated as more clinically serious. Recently, we've expanded the application of BLIS technology to include peri-implantitis. Even when we perform surgical treatment for peri-implantitis, it's difficult to determine whether biofilm remains on the implant threads. Although lasers are often used to remove it, if we could actually visualize where the biofilm remains, the removal process would be much more effective and the surgical outcome would be significantly improved. What's more, if active and acute inflammation is already present around the implant sulcus, we'll observe a distinct red fluorescence as shown here. In such cases, I often insert a paper point into the sulcus, commonly used in endodontics, and a significant amount of exudate comes out, making diagnosis easier. When examining implants that have been extracted due to peri-implantitis, we often find that biofilm remains adhered to the surface. I believe the future of peri-implantitis treatment will center on how effectively we can locate and remove biofilm from the implant threads. I'd like to briefly go over a few important precautions when using these imaging devices. First, you should be cautious of ambient light. It can interfere with the pure natural fluorescence created under 405 nanometer light, which may compromise image accuracy. Second, since you need to first focus using the white light image and then capture the blue light fluorescence, it's essential to allow enough time inside the oral cavity. For those accustomed to capturing just one image at a time, this dual image process may initially lead to errors. Patience is key. Wait until both images are successfully captured to ensure high quality results. Third, I recommend removing any biofilm covering the natural tooth before imaging. This allows for accurate detection of intrinsic abnormalities in the tooth structure. Now let me introduce our non-imaging devices. These are light curing type devices. However, instead of traditional curing functionality, they emit 405 nanometer light specifically designed to visualize bliss-based fluorescence. Dental hygienists and dentists can use it chairside, after or during scaling, or while removing caries. Personally, I often use it during peri-implantitis surgery or treatment. It's highly effective for identifying residual resin or detecting any remaining caries. So I'd like to emphasize that this is one of the easiest and fastest tools clinicians can use for real-time chairside decision-making. QScan Plus is designed for the general public to use at home for self-care. After we capture a QC image at the clinic to visually show the patient their biofilm status, we demonstrate that the same features can be viewed using QScan Plus. When children review their LinkedIn's QC image at home, they can use QScan Plus to monitor those same areas, turning oral hygiene into a sort of game and becoming more engaged in their own care. This approach has proven effective in producing significant improvements in oral hygiene. The effectiveness of LinkedIn's increases dramatically when the app is paired with QScan Plus. When patients receive their QC images through the LinkedIn's app and compare them at home using QScan Plus, it greatly enhances their ability to manage oral hygiene. Here's a real-life example. This patient visited our clinic in January of this year. The patient had a significant amount of biofilm, which we confirmed had been removed post-scaling using the VU device. After scaling, we showed the patient a comparison between their pre-scaling QC image and their current condition using QScan Plus. That was the first visit, and when the patient returned 2 weeks later, we observed clear improvement. The remaining issue after removal was intrinsic to the tooth itself, proximal caries. This case illustrates how oral hygiene can improve with the use of QScan Plus. And now I'd like to explain how we represent this improvement through our strongest advantage, quantitative and qualitative evaluation. We aim to provide patients with both quantitative and qualitative evaluations of surface caries and overall oral hygiene. In medicine, diagnostic results are already commonly expressed in numerical values, but dentistry still lacks this level of objectivity. That's why we've spent years working to standardize and quantify these diagnostic outcomes. Dr. Elbert, the founder of QLF technology, emphasized the Q in QLF, meaning quantitative, or the ability to measure changes objectively. Through his brilliant insight, he created a method in which clinicians can designate a healthy area on a tooth using a mouse, and the system then calculates how much fluorescence loss has occurred in other areas relative to that healthy region. This analysis is divided into two key metrics, delta F and delta R. Delta F measures how much fluorescence has diminished. This is typically calculated using the red to green RG fluorescence ratio. We set a threshold at -5, meaning that if delta F exceeds this value, we can confidently identify surface level changes or abnormalities. Delta R is derived from the red R value of the RGB spectrum. When the red value exceeds the normal by more than 20%, it indicates a clinically significant issue. This is why it's critical to control ambient light during imaging. Uncontrolled ambient light can introduce false red fluorescence, which skews results. So our software helps clinicians guide and mark what they consider normal regions. Once the normal areas are marked, typically in blue, the system automatically calculates and compares those values against abnormal regions within the same image. Among these values, we also identify the most affected point, which we call delta F max. My co-founder, Professor Baikil Kim, and his team have published numerous studies showing a strong correlation between these metrics and the actual stages of caries progression. Relying solely on RGB values made it difficult for AI to distinguish whether fluorescence loss was due to prosthetic materials or actual dental tissue. So we moved beyond the traditional RGB model and developed a new concept based on two color difference systems using LAB values. We call this multichromatic analysis, or MCA. The core objective of MCA is to enable automatic analysis through AI. With MCA, we've already achieved over 98% accuracy in separating tooth structures from gingiva across numerous clinical cases. We applied clustering algorithms to over 700 segmented cases, analyzing more than 440 million pixels using their LA and RG values. Through this clustering, we found that RGB values could be mapped as specific borders within the LAB color space. This result is what we refer to as the MCA map. We identified 4 main clusters. Areas shown in black typically represent prosthetic materials or fillings. Since prosthetic regions can also pose risks, we highlight only truly healthy natural enamel in green, while biofilm and prosthetic materials are marked in red. The intermediate overlapping zones are displayed in yellow. This MCA map, generated based on LAB coordinates, enables both qualitative and quantitative evaluation of tooth health by spatially plotting pixel data. This process allows AI to automatically perform the analysis, and it accurately recognizes natural teeth in the process. Once the AI has processed the image, users can isolate and visualize specific zones, red, yellow, or green, depending on the clinical need. You can also define the healthy region, and the corresponding green areas and RGB data will be simultaneously displayed. While the image on the right provides a qualitative explanation, the graph on the left delivers a quantitative assessment in the form of a hygiene score. This isn't just about diagnosing disease, it also visualizes the quantity and distribution of plaque. We're also conducting ongoing research on how this method applies to carious lesions. Images like the one shown here are processed by AI and categorized into 3 zones. You can see distinct green, yellow, and red regions. If you click on a region of interest with your mouse, a corresponding point appears in the bottom left graph. The purple dot shows where that pixel falls within the MCA map, helping us understand the chromatic profile of the selected area. The precise numeric values for that zone are also displayed in the upper left corner. We are currently in the process of clinically validating this system. Our goal is to acquire Class 2 medical device certification so this system can be used for official diagnostic purposes. If the highlighted region is moved upward on the map, you'll notice that the corresponding numeric values also shift accordingly. For example, MCAF max may increase from 0.29 to 0.39 depending on the selected region. In addition to blue fluorescence images, the AI can also analyze changes in white light images to detect improvements or deterioration. For instance, if the original brightness was -17.5 and whitening increased it to around 6, the visual output would look like this. If the brightness increases to 12, you can see the teeth appear this much whiter, and if the value rises to 18, the model can predict how white the teeth will appear, allowing for clear patient communication and counseling. That's because when we use BLIS technology, we can present both fluorescence and white light images simultaneously. This allows clinicians to make informed decisions about whether to proceed with whitening or restorative treatment by observing natural tooth cracks or caries visible in the fluorescence image. So incorporating white light image analysis alongside fluorescence data provides a more comprehensive and efficient diagnostic approach. And as shown, we can also use AI to visualize the degree of color change before and after whitening. With both the traditional QLF technology and the AI-powered MCA system, we provide 2 complementary tools that clinicians can choose based on their specific diagnostic goals. That concludes our overview of BLIS technology, and thank you very much for your attention.